Everybody hi. Ventricular arrhythmias remain a leading cause of morbidity and mortality in patients with cardiovascular disease. Device therapy with implantable cardioverter defibrillators, ICDs, has long been the cornerstone for those at highest risk. However, recent data, including the podcast trial presented at the 2025 European Society Cardiology Congress, demonstrate that proactively targeting plasma potassium in the high normal range 4.5 millimoles per liter significantly reduces arrhythmic events, arrhythmia-related hospitalizations, heart failure admission, and mortality in ICD recipients. These findings compel cardiologists to reconsider potassium management not only to device carriers but also for the broader population of high-risk patients who remain without ICDs. The biological basis. Adequate extracellular potassium stabilizes myocardial cell membranes, enhances repolarization reserve, and reduces susceptibility to ventricular tachycardia and ventricular fibrillation. Hypokalemia, even mild, promotes early after polarizations, QT prolongation, and premature ventricular complexes, increasing sudden death risk, particularly in patients with heart failure, ischemic scar, or diuretic use. While correcting hypokalemia in hospital setting is standard, emerging evidence suggests that actively maintaining potassium in the upper normal range may prevent arrhythmias in ambulatory high-risk patients. Clinical evidence and the podcast trial. In high-risk ICD recipients, protocolized potassium optimization more than 4.5 millimole per liter reduces ICD therapies, unplanned arrhythmia, or heart failure hospitalizations and mortality. Multi cohort studies confirm that lower potassium levels are associated with increased arrhythmia events and sudden death across diverse cardiovascular populations, independent of ICD status. The protective effect of potassium optimization are not device-specific. Patients without ICDs remain vulnerable to the same electrophysiological triggers. Balancing benefits and risk. The main barrier to broad potassium optimization is the risk of overshooting, particularly in patients with advanced chronic kidney disease, diabetes, or those on renin-angiotensin system inhibitors. Evidence supports targeting 4.55 millimoles per liter with close monitoring to avoid values more than 5.5 millimoles per liter. Concomitant use of renin-angiotensin aldosterone blockers or mineralocorticoid receptor antagonist and necessitates tailored monitoring strategies. Who may benefit most? Patients with heart failure with reduced ejection fraction, prior myocardial infarction with SCA, left ventricular dysfunction, or frequent premature ventricular contraction, and non-sustained ventricular tachycardia, even without ICDs. Consideration. Heart failure with preserved ejection fraction patients or those on chronic diuretics with low normal potassium. How to optimize potassium? encourage dietary potassium, fruits, vegetables, low sodium potassium salt were not contraindications. Use MRI, spironolactone, eplerenone, firenone, or Tylerate oral potassium supplementation as needed. Monitor frequently, especially in patients with chronic kidney disease, diabetes, or polypharmacy. Maintain plasma potassium between 4.5 and 5 millimoles per liter, avoiding both hypokalemia and hyperkalemia. The need for broad trials. Podcast included only ICD recipients. Dedicated randomized controlled trials in high-risk non-ICD patients are essential to confirm benefits on arrhythmia and survival. Research should also address monitoring strategies, adherence, and cost-effectiveness of broad potassium optimization. If confirmed, potassium optimization could be a low-cost, widely applicable intervention integrated into high-frequency heart failure and arrhythmia prevention guidelines. The convergence of mechanistic insight, observational evidence, and randomized data suggests a paradigm shift. Potassium optimization should be considered a core strategy in arrhythmia prevention for high-risk cardiovascular patients, not only for those with ICDs. Clinicians must balance the benefits of targeting high normal potassium with vigilant monitoring for hyperkalemia. With broader clinical validation, active potassium management could emerge as a simple, physiological, and powerful tool to reduce arrhythmic deaths and hospitalizations. Maintaining plasma potassium in the 4.55 millimoles per liter range may offer substantial anti-arrhythmic protection. This approach deserves testing and adapting across high-risk patients, including those without ICDs, provided safety is carefully managed. Thanks for likes and sharing.